Hello learners, today we will be seeing a very interesting topic, that is macrocytic anemia. So in the CBME curriculum, it is the competencies from 15.1 to 15.4. So where we will be seeing the metabolism of B12, the etiopathogenesis of B12 deficiency, what are the relevant laboratory investigations, how are we going to identify and describe the peripheral blood picture of macrocytic anemia, and finally the difference between megaloblastic and non-megaloblastic macrocytic anemia. So let's unwind it. So what are the learning objectives? At the end of the session, all of you will be able to enumerate the causes of megaloblastic anemia, describe the morphology of cells in megaloblastic anemia, discuss the etiopathogenesis and the clinical features of B12 deficiency anemia, and also folic acid deficiency anemia. So we'll see. So first we'll start with some basics. So what is megaloblastic anemia? So it is a group of disorders in which the rate of DNA synthesis is retarded, whereas the RNA synthesis is normal. So here what happened? DNA synthesis. For DNA synthesis, you need vitamin B12 and folate. So when they are deficient, what happens? The rate of DNA synthesis is impaired, whereas the RNA synthesis is totally normal. So there is an imbalanced cell growth, because the DNA maturation is delayed, whereas the RNA is maturing at its own pace in a normal way. This not only affects the cells of the bone marrow, but also all the rapidly proliferating cells. That is the cells with the renewal of less than 24 hours, the gastrointestinal tract, the lining of the uterine cervix. All these cells will be affected. And it is caused by vitamin B12 or folic acid. Vitamin B12 and folate are needed for the synthesis of thymidine base pairs, an essential component in DNA synthesis. So this is the concept map of megaloblastic anemia, where we are going to link the etiology with the pathogenesis and ultimately the clinical features. So let's see this. So what happens? So this is vitamin B12 or folate deficiency. When there is a deficiency, what happens? So there is a retarded DNA synthesis, whereas the RNA synthesis is totally normal. So because of that, what happened? The cell division is getting delayed, whereas the cytoplasm is maturing in a very normal way. So what happens? The daughter cells will have more cytoplasm, that is the deranged nuclear chromatin, whereas the cytoplasm is ample. So the cells will be obviously larger because the cytoplasm is occupying more space and there is a delay in cell division. So how the cells will look? They are all very big. They are macrocytes and the nucleus doesn't mature. So there is an imbalance between the nuclear cytoplasmic maturation. So this is the crux of macrocytic anemia. So there is a nuclear cytoplasmic asynchrony. So that is the key feature in macrocytic anemia. So the person will have anemia, and with further divisions, what happens? Some of the cells will die or omit terminal differentiation. So only very limited cells will come to the peripheral smear. So there will be an anemia. There is an ineffective erythropoiesis. So what is the meaning of this terminology? Ineffective erythropoiesis. So because of anemia, what happens? There is an erythropoietin synthesis, and this erythropoietin will signal the bone marrow to produce more erythroid precursors. What happens? Whatever erythroid precursor that is being produced in the marrow is not going to come to the peripheral smear, because most of the cells are all abnormal because they have more cytoplasm and the nuclear maturation is not apt. So all those cells will die in the bone marrow itself. So that is what is called as an ineffective erythropoiesis. It means the erythropoiesis is not being effective. And all these cells, they die in the bone marrow. So there is a hemolysis that is happening, that is leading on to jaundice. So anemia and jaundice are the two key clinical features in B12 or folate deficiency anemia. So megaloblastic anemia, there is an impaired DNA synthesis leading on to the two key things, that is ineffective erythropoiesis and dyserythropoiesis. So the word dysplasia means abnormal. So there is an abnormal erythropoiesis. So the cells are all larger with more amount of cytoplasm and they are very immature. So the key feature in megaloblastic anemia in the pathogenesis is ineffective erythropoiesis and dyserythropoiesis. So what are the causes of this megaloblastic anemia? So vitamin B12 deficiency, folic acid deficiency and other causes. So in vitamin B12 deficiency, what happens? So there is a decrease intake, especially vegetarians, because vitamin B12 is specifically seen in non-vegetarian diet or somebody who is not at all taking food properly. Coming to the impaired absorption. So impaired absorption seen in pernicious anemia and autoimmune disease where intrinsic factor is not being adequately produced. Intrinsic factor deficiency, which is produced in the stomach. So obviously gastrectomy people, intrinsic factor is not being produced. Malabsorption. Ileal resection, because ileum is the site where B12 is absorbed into the circulation. Fish tapeworm, also called Diphyllobotherium latum. Bacterial overgrowth, blind loop syndromes. Folic acid deficiency, decrease intake, especially in alcoholics. Impaired absorption, malabsorption. People on anticonvulsant therapy, oral contraceptive pills. Hemodialysis people where folic acid is easily lost. Increased requirements, pregnancy, infants and cancer people where we are supposed to treat the people with prophylactic folic acid. Impaired utilization, folate antagonist. Unresponsive to B12 or folate therapy because of molecular mutations. Methotrexate, obviously it is a folate antagonist. So we'll see this with the case scenario. So we have a 52 years female, known case of type 2 diabetes mellitus on oral hypoglycemic drugs, especially metformin. So she developed a gradual onset of dyspnea on exertion and EC fatigability since 6 months. On examination, she is very pale with yellow discoloration of the sclera. So paler suggesting anemia and yellow discoloration of the sclera, which says the person is having a jaundice. And when you look at the stomach, when you look at the mouth, after stomatitis is there. When you ask her to pull out the tongue, beefy red tongue is there. So this is the paler, and this is the classic smooth, shining, beefy red tongue, which is the classic feature of megaloblastic anemia. And this is jaundice, yellowish discoloration of the sclera. So what are the neurological changes in vitamin B12 deficiency? Very, very important, because B12 is not only needed for thymidine base pair synthesis, but also for the myelin synthesis. So when the myelin synthesis is hampered, what happens? In the beginning stages of B12 deficiency, the person will have a poor gait and memory loss will be there. Late stages, severe disturbances in the gait, especially the position sense is lost, because vitamin B12 deficiency will lead to demyelination in the dorsolateral column of the spinal cord. Psychiatric disturbances, that is called as B12 madness. The person can have blindness due to optic atrophy. Glove and stocking numbness or glove and stocking neuropathy, where the person will have numbness in the palms and sole. Arterial or venous thrombosis leading on to cerebral infarct when there is a very severe B12 deficiency which is not being attended to. We'll see the complete blood picture. So this is our scenario. So this is our patient. So she has a hemoglobin of 4.3 with a very low hematocrit. Total WBC count in our patient is probably normal or slightly elevated. RBC count is low. See the mean corpuscular volume. So the MCV is very high. See, remember, whenever the MCV is more than 100, you can think of macrocytic anemia. When the MCV is more than 110, it is probably because of vitamin B12 or folate deficiency. So we are narrowing down the cause of macrocytic anemia to B12 or folate deficiency when the MCV is more than 110. MCH is abnormal, whereas MCHC will be, of course, normal. You can see the RDW. RDW is also elevated. The differential WBC count is normal. Platelets are also normal in this patient. So here, derangement in DNA synthesis because of the defect in thymidine base pair synthesis. So there is a apoptosis of precursors in the bone marrow, so that is causing ineffective erythropoiesis. And because of the apoptosis of the precursors in the marrow, not only the erythroid, but also the myeloid precursors, and there is an ineffective erythropoiesis, in the late stages, the person will present with the pancytopenia. So what is pancytopenia? So pancytopenia is anemia, leukopenia and thrombocytopenia, because this B12 deficiency is not only going to affect the erythroid precursors, but also the myeloid and the megakaryocytic precursors. So the person can have a pancytopenia. This scenario, the person is having only anemia, but the most common reason for pancytopenia is B12 deficiency. So before investigating for a patient with B12 for a pancytopenia, always it is imperative to do B12 and folic acid assay, because the most common etiology of pancytopenia is B12 or folate deficiency. So coming to the morphology, how the cells are going to look. See, you can see, so this is the first feature in macrocytic anemia. See, before even we get the macrocytes, so this finding will be there. As you can see here, this is a neutrophil. When you count the lobes, it is 1, 2, 3, 4, 5, 6, 7 lobes are there. So any neutrophil with more than 5 lobes, we call that as a hypersegmented neutrophil. And what you see here, so these are the bigger cells, they are the macrocytes. So they are the macroovulocytes. So macroovulocytes are basically larger cells without the central pallor. See, normal cells will have the central pallor, whereas macroovulocytes are the cells without the central pallor. See, here you can see the central pallor in this particular cell, whereas here it is not there. So they are the macroovulocytes. So they appear hyperchromic, whereas in reality they are normochromic, because the chromasia is based on the hemoglobin. So here hemoglobin synthesis is normal. So they appear hyperchromic, whereas they are actually normochromic. So the peripheral smear picture will be RBCs are macrocytic and normochromic. Marked anisopoikilocytosis. So anisocytosis is variation in the shape. Poikilocytosis is variation in the, anisocytosis is variation in the size, and poikilocytosis is variation in the shape. So marked anisopoikilocytosis will be there because some cells will be normal and some will be abnormal. So the variation will be very much marked. So as I have already said, this is a hypersegmented neutrophil. The first finding in macrocytic anemia will be hypersegmented neutrophil. Hypersegmented neutrophil is neutrophil with more than 5 lobes. So if you see more than 5% of neutrophils with more than 5 lobes, you can call that peripheral smear picture as hypersegmented neutrophils are seen, suggestive of macrocytic anemia. So that will be the first clue. And here what you are seeing, this particular cell, is that the RBC crying. So it is a teardrop cell. So teardrop cells will be there because when the bone marrow is overcrowded, all these erythroid precursors have to negotiate in a crowded space. So as they move through the crowded space, what happened? The morphology is altered into a teardrop cell. And here you can see this beautiful dot over here. So this is that jolly cell that is called Howell jolly body. Howell jolly body is seen in macrocytic anemia due to B12 deficiency. Also remember in splenectomy, because spleen is going to do the culling and pitting. So when the spleen is removed, what happens? The RBC cleaning will not happen. So I always tell like this, remember it this way. So whenever spleen is not there, these Howell jolly bodies are jolly well happy and they are jolly moving around the blood circulation. So Howell jolly bodies are seen in megaloblastic anemia and splenectomy. So they are basically the nuclear remnants. Because the thymidine base pair synthesis is abnormal, these Howell jolly bodies are seen. So much more pictures. So you can see these erythroid precursors in the peripheral blood smear. So they are all the immature erythroid precursors. So this is basically a late erythroblast which is seen in the peripheral smear. So this is a nucleated RBC. To be specific, it is a late erythroblast. So around 1 to 10 per 100 WBC will be seen in a megaloblastic anemia. And see again the problem in the DNA synthesis. So this is basically the nuclear remnant Gabot's ring. So the beautiful Gabot's ring. So remnant from the mitotic spindle. So this is the Gabot's ring, which is a very characteristic feature of megaloblastic anemia. And here you can see the RBCs with many blue colored dots. So this is basophilic stippling. Again remember, basophilic stippling is seen not only in megaloblastic anemia but also in lead poisoning. Very important MCQ. So basophilic stippling are the aggregates of ribosomal RNA. Finally, so this, as you can see, these RBCs are all pink in color, whereas these RBCs are sort of bluish in color. So this is polychromasia, increased basophilia we call it as. So this basophilic picture is again suggestive of dyserythropoiesis, a very classic picture seen in megaloblastic anemia. So these are all the peripheral smear pictures which we see in megaloblastic anemia. Now after completing the peripheral smear picture, we'll see the bone marrow picture. As you can see here, the bone marrow is overcrowded and the blue things are all the erythroid remnants and the pink things are the myeloid precursors. As you can see, the myeloid precursors are all very big. They are all the giant cells. So giant myelocytes. So this is a giant myelocyte and this is a giant metamyelocytes. So the giant myeloid precursors will be there, and the blue things are all the erythroid precursors. They are also bigger. If you can appreciate the nuclear chromatin, so this is all open chromatin. Open with the sieve-like chromatin. You can see the sieve-like appearance over here. All the cells will have the open sieve-like chromatin. So what is the bone marrow picture? So the first and foremost will be marrow is hypercellular. It is working 10 times than its normal capacity. So it is a hypercellular marrow. Erythroid hyperplasia. Obviously the erythroid precursors will overwork. So there is a reversal of myeloid erythroid ratio. See, normal myeloid erythroid ratio is 3 to 5:1. Whereas here what happened? More of erythroid precursors will be there. So the ratio is totally reversed. Megaloblast will be there. All these cells are bigger. Why they are all bigger? Because cytoplasmic maturation is more. Nuclear maturation is delayed. So there is an imbalanced cell division that is happening. Nuclear cytoplasmic asynchrony, which we have already seen. Open sieve-like chromatin. The chromatins are all abnormal. They are actually, when the cell matures, the chromatin should close. But here, because the cell is not maturing, there is a open sieve-like chromatin, which is a very classic feature in the bone marrow examination of megaloblastic anemia. Finally, as I have already said, giant metamyelocytes and band forms will be seen. Reticulocyte count. It is very, very important test. See, after ordering the CBC, you will look at the peripheral smear. After seeing the peripheral smear, before going for a bone marrow, you can of course do this reticulocyte count. A single test which will have two significance. One is it will make a diagnosis of megaloblastic anemia. Number two is therapeutic significance is also there for this test. So reticulocyte count, you know that reticulocyte will be done by supravital staining. So this is a new methylene blue staining. Previously, we were using brilliant crusyl blue to do the reticulocyte count. These days, we use a stain called new methylene blue, and these are all the reticulocytes. You can see here, these are all the reticulocytes. So, in megaloblastic anemia, the reticulocyte count will be definitely abnormal. So, what is the reticulocyte? It is actually the erythroid precursor which has lost its nucleus and it has to come to the peripheral smear. So, the stage before the RBC is the reticulocyte. Reticulocyte will have a lifespan of 24 hours in the peripheral smear. So, the stage before it is getting released into the peripheral smear is the reticulocyte. So, the reticulocyte count in the macrocytic anemia will be very low. Another significance is that reticulocyte count can be used for monitoring the prognosis. The moment you are giving injection of vitamin B12 and folic acid tablet, the person will respond in a very rapid way. If you check the reticulocyte count after giving injection of B12, within 48 hours, the reticulocyte count will become normal. So, which will definitely give a very important clinical clue that the person is having a B12 deficiency. So, this reticulocyte count is used to make the diagnosis and also to monitor the prognosis whether the person is responding or not. So, something about the vitamin B12 metabolism. As you are aware, vitamin B12 is present mainly in non-vegetarian diet, to certain extent in the milk. The daily dietary requirement, as you can see here, is very minimal. It is only 2 to 3 micrograms per day is what is needed. So, coming to the vitamin B12 metabolism, how vitamin B12 is being absorbed. So, this chart will help us understand the pathogenesis and the clinical features in a much better way. So, as you can see here, a diet which has vitamin B12. So, the vitamin B12 is in the diet along with the proteins. So, it is being eaten up. So, the moment vitamin B12 gets into the esophagus, what happens? So, the salivary gland starts secreting the saliva which produces this R binder. So, this R binder protein, once it is produced in the mouth, enters into the stomach. So, this vitamin B12 along with the protein complex enters the stomach. In the stomach, by the action of pepsin, this protein is getting released and this vitamin B12 comes and binds with this R binder in the stomach. And at the same time, the parietal cells of the stomach produce the most important carrier molecule for vitamin B12, that is the intrinsic factor. So, this intrinsic factor, vitamin B12 along with this R binder, travels along the duodenum and it enters into the ileum. So, in the ileum, this splitting of this R binder with the B12 happens, and in the ileum, vitamin B12 binds with this intrinsic factor. And now in the ileum, there is a specific receptor for the intrinsic factor which is called as the intrinsic factor receptor. So this vitamin B12 binds with this intrinsic factor, and intrinsic factor receptor is binding and it is internalizing vitamin B12 in the portal circulation. In the portal circulation, this trans-gopalamine 2, it is carrying this vitamin B12 all along the circulation. So this is the mechanism, and any problem in intrinsic factor synthesis or any problem in absorption of this vitamin B12 through the intrinsic factor receptor, the person can have a B12 deficiency in addition to the dietary deficiency. So what is the name of this R binder? Very important MCQ. It is called haptocorin. The other name for R binder is haptocorin. Similarly, what is the name for this intrinsic factor receptor? It is called cubilin. Cubilin is the intrinsic factor receptor. Also remember this trans-gopalamine 2, which is a carrier for B12 all along your circulation. So this is the normal mechanism of absorption of vitamin B12, whereas if you are giving injection in a very high dose, when you give mega dose of vitamin B12, what happens? Directly it will be absorbed in the circulation. See, that is the therapeutic significance where we are giving directly injection of vitamin B12, which will be directly absorbed. Passive diffusion will be there for vitamin B12. So again to remember, so the key molecules needed for erythroid synthesis is iron, folic acid and B12. Iron absorption happens in the duodenum, folic acid in the jejunum, B12 as you have seen in the ileum. So very important MCQ. So what is the etiology of B12 deficiency? We have already seen low vitamin B12 intake in vegetarians, alcoholic and elderly people. Autoimmune because of pernicious anemia and other autoimmune disorders like Sjogren's syndrome. And malabsorption, any problem in the stomach, because now that you know, in the stomach, intrinsic factor is being produced, and only in the stomach, pepsin acts up and the R binder is getting released. So, atrophic gastritis, chronic gastritis, H. pylori gastritis. Surgery, if the stomach is not at all there, post-gastrectomy, problem in the ileum, and we do a ileal resection. And because absorption is happening in the small intestine, so any problem in the small intestine will affect B12 absorption. Oral contraceptives, hormone replacement therapy and pregnancy. Trans-gopalamine 2 deficiency. So this is a genetic reason, and drugs which will inhibit which will utilize B12 or inhibit B12 metabolism. Also remember Diphyllobotherium latum, which is fish tapeworm, which will cause B12 deficiency. So what is the biochemical function of vitamin B12? Because this is the reason for the neurological functions as well. So this chart you are already familiar with. So vitamin B12 gopalamine is needed for the conversion of homocysteine to methionine. So where is this methyl group given to gopalamine? It is because of this N5-methyl tetrahydrofolate. So this is getting converted to tetrahydrofolate. So tetrahydrofolate is the key mediator which is needed for the DNA synthesis, which is needed for the conversion of this deoxyuridine monophosphate to deoxythymidine monophosphate. So this reaction needs folate. What we need to understand here is, so this this one carbon metabolism where this tetrahydrofolate, so it is a one carbon acceptor. It will get the fragments from this serine and figlu, that is formiminoglutamate acid. So through this one carbon pool also, this tetrahydrofolate can synthesize thymidine base pairs. So understand this clinical relevance of this particular concept. Remember, even without vitamin B12, if there is a folic acid available, thymidine synthesis will happen and anemia will be corrected. Because directly also through this mechanism, we can produce thymidine base pairs. However, remember, vitamin B12 is needed for another very important chemical reaction in the body, that is a conversion of methyl malonyl CoA to succinyl CoA, where you need vitamin B12 as a coenzyme. So if this reaction doesn't happen, what happens? So this precursors of methyl malonate and propionate will accumulate. So if they accumulate, what will happen? So they tend to accumulate in the myelin. So they deposit in the neuronal lipids, causing myelin breakdown. So that is the reason for the dorsolateral column of the spinal cord getting affected, leading on to all the neurological manifestations in vitamin B12 deficiency. So if you are treating the patient only with folate, the anemia will be corrected, whereas the neurological manifestations of B12 deficiency will be worsened. So whenever you are treating a person with macrocytic anemia, so you cannot treat folic acid alone. Always remember to treat both simultaneously, vitamin B12 as well as folic acid. So give mega dose of vitamin B12, then you give folic acid tablets. So if you treat the person only with folic acid, what will happen? The person will land up with the neurological manifestations. So little bit about pernicious anemia, which is an autoimmune disorder, autoimmune gastritis. So there are three types of antibodies. So type 1 antibodies are targeted against this intrinsic factor vitamin B12 complex, which will destroy this intrinsic factor B12 complex. So the person will have a B12 deficiency. Type 2 antibodies are targeted against this intrinsic factor receptor. Now you know the name of this intrinsic factor receptor, it is tubulin. So tubulin receptor, if there is an antibody against this thing, B12 absorption will not be there. Type 3 antibodies are against the alpha and beta subunits of the proton pump in the parietal cells. So as we are aware, the parietal cells produce this intrinsic factor. So once intrinsic factor is not there, the rest of the metabolism will be affected. So this is the etiology of this pernicious anemia or autoimmune gastritis, where the person will have B12 deficiency leading on to macrocytic anemia. So this pernicious anemia, because there is autoantibody synthesis in the stomach, it also affects the intestinal epithelium as well. So as you can see here, so this is the epithelial lining, this is the stomach, where you can see the atrophy of gastric mucosa, with you can see the goblet cells here, there is a intestinal metaplasia, and you can see the prominent lymphoplasmacytic infiltrate in the submucosa. And finally, there is a loss of parietal cells. We can't even see the parietal cells in the gastric biopsy. So to these people, what we have to do, we have to give them injection B12 and monitor the reticulocyte count, whether the person is responding or not. Because when you give injection B12, it will be directly absorbed by passive diffusion. So pernicious anemia is insidious in onset, leading on to moderate to severe megaloblastic anemia. In the peripheral smear, in addition to anemia, the person will have leukopenia with hypersegmented neutrophils. Elevated levels of homocysteine and methyl malonic acid will be there, because we have already discussed vitamin B12 is needed for this metabolism. Serum antibodies to intrinsic factor. So this assay is very much available. You can order for serum antibodies to intrinsic factor, which will give you the diagnosis of pernicious anemia. And when you treat the person, there will be outpouring of reticulocytes and hematocrit will be elevated with 5 days of vitamin B12 therapy in these particular patients. So what we are concerned about pernicious anemia is, despite treating the anemia, what happens? As we saw in the previous slide, there is an intestinal metaplasia and there is an intense lymphoplasmacytic infiltrate. So these people will have gastric adenocarcinoma and maltoma, mucosa associated lymphoid tumors. So despite B12 therapy, because of this metaplasia and increased lymphocytic infiltration in the submucosa, people with pernicious anemia can have they have a high risk of gastric adenocarcinoma and maltomas. So we'll move on to folate deficiency. See here, the daily requirement is compared to B12, it is more. B12 hardly 2 to 3 grams are enough, whereas for folate, daily requirement is nearly 50 micrograms per day. So folate deficiency will manifest earlier. So if a person is having a folate deficiency, it will manifest within weeks to months, whereas a B12 deficiency will take months to years. So you know now that tetrahydrofolate is an intermediate in 1-carbon metabolism. So in the food, it is available as polyglutamates, which is very heat sensitive. So when you cook the food too much, most of the folate will be lost. So intestinal conjugases, these enzymes help to split the polyglutamates into monoglutamates. So the absorption is in the proximal jejunum. Again a recap, iron in the duodenum, folate in the jejunum and B12 in the ileum. What is the transport form? It is N5-methyl tetrahydrofolate, and deficiency will manifest in weeks to months because the daily requirement is higher. It is especially seen in alcoholics with cirrhosis of liver. They are more prone to have folate deficiency. Causes of megaloblastic anemia. Now we have completed about vitamin B12 deficiency. So in folate we have already seen in alcoholics. Malabsorption, any problem in the small bowel because it is absorbed in the jejunum. Hemodialysis patients, it is increasingly lost. Prophylaxis needed in pregnancy, infancy and cancer people, and folate antagonists like methotrexate. So when you come to the decision making, you want to know whether the person is having a B12 or folate deficiency, the best key is to do a biochemical test. Biochemical levels of B12 and folate in the serum can be estimated. So, since folic acid can reverse the hematological damage caused by B12, not neurological changes. So, very important, again re-emphasizing the concept, neurological changes will get worsened when you administer the patient with folate alone. So, always treat the patient with B12 and folate simultaneously. So, whenever we have the dilemma, so some clues, onset will be chronic in a B12 deficiency. So, it will take years, minimum 3 years is needed whenever a person is having an outblown deficiency, whereas folate will be acute within weeks to months. Clinical features will be similar in both the cases, even the CBC, peripheral picture, bone marrow, all will be the same. When you do the specific assay, in B12, serum B12 levels will be decreased. In folate, the most specific assay will be the red cell folate levels. Serum folate level will give reliable results, but more specific will be red cell folate. So, both will be decreased in folic acid deficiency. Homocysteine levels will be obviously elevated in both. Whereas the serum methyl malonate levels will be elevated in B12, whereas it will be normal in folate deficiency. So, how do you manage the patient? For B12 deficiency, we have to give injection hydroxygopalamine, intramuscular injection to be given. So, 1000 micrograms, initial dose will be 6 doses for 3 weeks duration, followed by maintenance of 1 injection every 3 months. Prophylaxis is needed in gastrectomy people and ileal resection people. Folate, it is only tablets, orally 5 milligrams, daily for 4 months, and maintenance depending on the etiology, whether it is lifelong, especially in dialysis people, they should be always supplemented, and prophylaxis needed during pregnancy, hemolytic people and dialysis people. So, to conclude, macrocytic anemia, most common reasons is because of B12 or folic acid deficiency, and the most common pathogenesis is ineffective erythropoiesis and dyserythropoiesis. In the clinical features, you have to remember anemia and jaundice, the most important clinical features. And in the management, always remember we have to supplement both B12 and folate. Folate alone will lead on to neurological manifestations of B12 deficiency. So, always treat the patient with both B12 and folic acid. Thank you.